everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the February 2024 issue dedicated to thyroid and parathyroid disease, guest edited by Drs. Amy Y. Chen and Michael C. Singer. Here now is our consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. And today I'm speaking with the guest editors of the February 2024 issue of Clinics, which is on thyroid and parathyroid disease, Drs. Amy Chen and Michael Singer. Dr. Amy Chen is professor and vice chair and director of endocrine surgery in the Department of Otolaryngology, Head and Neck Surgery at Emory University in Atlanta, Georgia. Dr. Michael Singer is professor of otolaryngology at Michigan State University and director of the Division of Thyroid and Parathyroid Surgery at the Department of Otolaryngology, Head and Neck Surgery at Henry Ford Hospital in Detroit, Michigan. You can find this issue, each article, and all our previous issues and podcasts at www.oto.theclinics.com. You can hopefully also find each issue in your personal or institutional library. So welcome, Amy and Michael, and thank you so much for doing this issue.
Pleasure to be with you.
Awesome. Thank you.
So let's get started. I'm going to direct the first question to Dr. Chen. So Amy, in the preface, which I really enjoyed reading, I really enjoyed reading and rereading every part of this issue, actually. But in the preface, you discuss how thyroid surgery has been described in the past as, quote, horrid butchery, end quote. So what has changed? What has allowed modern thyroid and parathyroid surgery to become safer and more effective?
Well, thank you so much for the opportunity to guest edit this important volume. And I wanted to point our attention to your forward as well, because you outlined several of the reasons as to why this surgery was called horrid butchery. It's important to remember that Halstead reported a 40% mortality rate with thyroid surgery. And you also reminded us in your forward that the French Academy of Medicine banned all thyroidectomy in 1850. It really wasn't until anesthesia, antisepsis, and hemostasis that thyroidectomy became tolerated. At that time, Bill Roth saw his mortality rate drop to less than 10%, and then Coker dropped his mortality rate to less than 1%, earning himself a Nobel Prize in 1909. Furthermore, there have been more recent advances in nerve monitoring, nuances of surgical decision-making, diagnostic developments in nodule interrogation, knowledge of clinically low suspicion disease, and advancements in non-surgical management of nodules.
So I think, like with most aspects of medicine, I think we're becoming keener observers of what needs intervention, what doesn't need intervention, and maybe better diagnosticians at making those distinctions, would you say?
Yes, absolutely.
Dr. Singer or Michael, what technologies or approaches do you think are going to have the biggest impacts in the field going forward?
Yeah, so I would just, as a follow-up to Amy's comments, I would just add that thyroid surgery, like Amy said, has changed dramatically. But even in the last 2 or 3 decades, the changes have really kind of been fundamental. Conventional thyroid surgery up until about the 1990s was done largely in the same manner as it was done in the 1900s. And then because of the introduction of a number of technologies, and as a result, a number of techniques that were able to employ those technologies, thyroid surgery, parathyroid surgery has just become less invasive, has become less traumatic for patients both intraoperatively, postoperatively, and really kind of the whole face of endocrine surgery, at least in the areas of thyroid and parathyroid surgery, have really, I think, fundamentally changed. And I think it's an important point just to make that it's not technique alone and it's not technology alone. It's really a synergism between those two that I think have allowed for endocrine surgery to kind of evolve as dramatically as it has. That being said, I really think that we're kind of at a turning point again in the field. There are kind of technologies that exist that I think are going to really impact the full gamut of elements of the type of care we deliver. And that ranges from both diagnostics, imaging techniques, and certainly interventions. For example, with diagnostics, artificial intelligence is something that's going to just fundamentally change the way that we approach a lot of patients. Obviously, this is not limited to endocrine surgery. It's not just limited to surgery. This is true, artificial intelligence, you see it everywhere. People are constantly talking about it. But for example, one of the holy grails within endocrine surgery is being able to simply look at, say, with ultrasound or other imaging technology, and be able to recognize and confidently be able to tell patients whether that nodule is a malignancy or not, right? So this has evolved from the time prior to biopsies, where it was, oh, that feels firm, that feels fixed, so therefore it's probably a malignancy, to fine needle aspiration, ultrasound assessment of nodules to try and make those determinations. And then obviously, I think everyone is familiar with the Bethesda system for cytologic assessment of nodules. And then, of course, the most recent iteration or evolution has been molecular studies. Ultimately, though, we're still doing a large number of diagnostic surgeries where we can't definitively say to a patient, yes, this is a cancer, or no, it's not. And so therefore, we're essentially doing surgery to determine whether it's cancer or not. And so I think that things like machine learning are going to really, and I don't mean in 20 or 30 years, I think in the next 5 to 10 years, there's going to be a dramatic shift where, with ultrasound evaluation and then correlation with surgical outcomes, we're going to be able to, with a much greater degree of precision, be able to say to someone before surgery, yes, this is cancer, or no, it's not. Now, that patient still may need surgery for compressive reasons, for example, but I think that that is going to be like an area where, again, it's just going to fundamentally change because of technology. I think another area that is going to obviously be dramatically impacted is, I think, the way we do surgery at this point. And again, I don't think this is 25 years from now. I think we're right on the cusp of this, is going to really change in that, to date, when we look at the surgical field looks the same as it did at the time of Theodore Coker, right? So everything is shades of white and red and blue. And what we see, and the perfect example of this is discussed in this chapter on future directions in the treatment of thyroid and parathyroid diseases, that there's a discussion about autofluorescence imaging for parathyroid recognition. And between optical imaging techniques, between augmented reality, I think we're really probably, again, just on the cusp of the way that the surgical field appears to us as surgeons is going to look very different. So there's this idea out there of color-coded surgery, that this is going to start to look more like, say, for example, a Frank Netter atlas, where, the nerves are yellow, the thoracic duct is green, the arteries are in red. And what that's going to do is, I think it's really going to democratize the field. And what I mean by that is the amount of expertise, the amount of experience someone's going to have in order to become at least a pretty good surgeon is going to drop significantly. And again, what's amazing to me is that I've thought about this for a long time, and I thought, like, this is never going to happen in my career. And already there are technologies that are emerging that people are going to be seeing these in their hospitals, in their ORs, even in the next few years.
You know, when you said that, it was so funny because I remember the first day of gross anatomy dissection and hanging out with my cadaver and realizing that the nerves are in fact not yellow and the tendons are not white while the muscle is more pink. You know, it was very funny because subliminally, even though I'm not as dumb as this appears, but subliminally you're just kind of like, oh yeah, that's what it's going to look like. It's going to just look like this atlas I examined. That is very interesting. And I think it lends itself, as you said, to preparation for surgery, maybe in a virtual reality atmosphere, and then improved surgical outcomes, maybe in an augmented reality atmosphere. As you guys know, I'm an otologist neurotologist, and there's a lot of very interesting work being done about fluorescence and autofluorescence to distinguish vestibular, cochlear, and facial nerves in the IAC and brainstem. So this is really, as you said, not limited to one area or even one subset of medicine, but everywhere. You guys included some really nice articles on the otolaryngological and endocrinological perspectives as an overview of thyroid and parathyroid disease. And I have to tell you that the tables 1 and 2 on the diagnostic, evaluation, and management of conditions that may require thyroid surgery, which is table 1, or parathyroid surgery, which is table 2, in the articles by Dr. Kanan and Liang is really, really good. Those tables are very useful. I wonder, Amy, I see that one area that has seen a tremendous change in the last decade is what we do with well-differentiated thyroid cancer. So I think Michael pointed out that, you know, somebody's got a lump in their neck, you know, somebody's got an abnormality, they get the ultrasound, they get the remainder of the imaging, they decide to go for surgery. Now you find not an anaplastic tumor, but a well-differentiated cancer. So what is this concept of de-escalating therapy, and how does that apply to these tumors?
So I think that's a great question. And if we follow along the American Thyroid Association guidelines, there has been some massive shifts. Early in my training, it was pretty much if you had a cancer, you took out the whole thyroid. It didn't matter how small, how big, how anything. It was just everything came out. And then it became an area where, oh, maybe we're diagnosing too many thyroid cancers. So let's pause the needle in terms of the fine needle biopsy, and we should only aspirate nodules that meet this criteria or that criteria. And that seemed to stem the tide a little bit. Then we became more nuanced about, oh, well, maybe if it's less than 4 centimeters, we don't need to take out the entire thyroid. We can just do a partial, especially if there are no lymph node involvements. But then, you know, now we have molecular diagnostics as a great interrogator of thyroid nodule mutations. And that added even more nuanced. So I think that the quote unquote de-escalation is anything other than a total thyroidectomy. Is what the de-escalation has become.
And so this seems to be much more personalized medicine, as we're reading about in breast cancer, for example, for the last decade or so. Are patients and their families, Michael, comfortable with, well, you have cancer, but it's, you know, these are the data points we're using to not do a completion thyroidectomy. Are patients and their families comfortable with that?
Yeah, I mean, it's one of the things that I personally am amazed by is how few people I have to kind of convince to not have a total thyroidectomy. You know, a lot of this comes down ultimately to our relationships with the patients, right? You know, I still think, even though society-wide there's been a move towards, you know, internet-based medicine and a de-emphasis of kind of experience and expertise, I find that most of my patients, when I say to them, this is an option, because that's the key, it's an option, is most of my patients are very open to it, but this goes down to the individual, this is patient-centered care. I have patients who, based off my knowledge, based off what the evidence suggests, that probably a hemithyroidectomy alone for them is sufficient. And, I'll discuss a total with them. And for whatever reason, they're very anxious. They have a family member who had thyroid cancer and it recurred multiple times, whatever else it is. And they'll say, you know what, I feel more comfortable with total thyroidectomy. And I always am at least willing to discuss it as long as it's a reasonable option. But I've been impressed by actually the opposite, which is the percentage of patients who I think pretty quickly say, oh, as long as you feel comfortable with this, I feel comfortable with it. I always kind of thought initially when this idea came along, and this idea has been out there for actually a number of years, is that largely based off of work from Memorial Sloan Kettering, that as long as we use the word cancer, people were going to be kind of scared into doing more. And again, I've been surprised at kind of most people's willingness to say, hey, if I can do less, let's do less. And I would just say that the critical point with this is that it's de-escalation while having outcomes that are as good. So, what the data says is not, oh, you can have a hemithyroidectomy, but what that means is that there's a 5% chance more that it's going to recur or that you're going to have invasion somewhere or anything like that. And that's not what we've figured out. What we've figured out is we can do less intervention and still have ultimately the same results. And obviously from a patient perspective, but even from a surgical perspective, if I can do less and the patient is going to do just as well, I think that's always an advantage.
And then how are these patients followed? Is this sort of a partnership between you and the endocrinologist or you and the internist? What is maybe in like 3 steps? Like what would you say is the correct way to follow these patients?
Everyone has a slightly different practice pattern. In my practice, largely the follow-up is being done by endocrinologists. What changes in these patients is a lot of their follow-up becomes much more reliant on ultrasound imaging, as opposed to, say, for example, if you do a total thyroidectomy, you can use ultrasound plus you can use the blood test of what's called thyroglobulin, which is a kind of a protein marker for thyroid cancer or thyroid cells. You can still do that if a patient has half of a gland remaining. There's questions about how much value there is, but it definitely becomes more dependent on ultrasound imaging. But some of it is really about our ability, again, just to say we have years and years and years of data that supports that this cancer is so small that we really don't have to be particularly concerned. Again, that doesn't mean that surveillance is not necessary, but I think it's what allows patients to feel comfortable with a little bit of a compromised, I'd say, ability for surveillance, knowing that the data is out there to kind of back this approach up long term.
That's really interesting. So you talked about augmented reality, trying to speed up the learning curve in thyroid surgery, but there is a learning curve in thyroid surgery, and doing thyroid surgery well, whether it's a cervical goiter or a substernal goiter, is definitely a matter of skill and paying attention to detail. And both of you have chosen to include 2 articles on the management of those particular types of goiters that really are gorgeous, step-by-step photographs and descriptions. Having done my last thyroidectomy a long, long time ago, I enjoyed remembering the points that my professors made to me back then. So I encourage our listeners to go back and look at those articles, because the pictures and the descriptions are really, it's like having your favorite professor across the neck from you in the OR, just kind of saying, okay, now do this and now do that. Even though I haven't done thyroid surgery for a long time, it turns out I own a thyroid and I own a voice. So I was very fortunate to be the chair of the American Academy of Otolaryngology's clinical practice guideline called Improving Voice Outcomes after Thyroidectomy. And I think, we're talking about minimally invasive surgery. We're talking about not doing more than is required. But the resultant voice after thyroidectomy is a real concern, not just to singers or people who use their voice professionally, but everyone uses their voice. So to everyone who wishes to actually communicate with their voice. So Amy, you included a nice article on monitoring of the recurrent laryngeal nerve. And over the last 2 decades, monitoring has become widespread, but not, 100%, but quite widespread. But we're also concerned about access to care. Both of you are practicing in major metropolitan areas, but I know that your catchment area brings people in from more rural communities or places where primary thyroid surgery may be done in a less intense academic environment. So we really want every patient to have access to high-level care. So can you describe some of the improvements with nerve monitoring that have led to broader adaptation of the technology, and where people really should be insistent that they need nerve monitoring and where it's not as necessary and can be done safely without?
Yeah, I think this is a very interesting topic. Just this week, one of the residents had asked me, when did you start using nerve monitoring? And I really had to think back, and I don't believe that we did it during training. I trained in the late 80s and 90s, and there was really no nerve monitoring. There was a little bit of nerve monitoring for otology cases, but definitely not for thyroid surgery and I think we used it for parotids for sure, but not for thyroidectomy. And so I said, it was probably when I started being in a faculty physician here. And I think that what is really great about the technology is that you don't need to have the fanciest equipment. You can just use a simple handheld nerve monitor, put your finger on behind the larynx, stimulate the nerve, and see if you can feel that larynx contract. That's the most simple way. Sometimes our nerve monitor breaks or isn't on the fritz, and we can't reliably use it. I'll pull out that little bitty nerve stimulator that you turn to go from 0.5 to 1 to it's not very sophisticated. It just stimulates the nerve. Put your finger on the end organ and see if it contracts. There's your stimulus. So I think that in this article that was in this chapter that was written by Dr. Kirky and Sinclair, there was a lot of great boxes and figures. And box 1 pretty much summarizes the recommendations. First, you want to check the vocal fold movement prior to surgery. Usually we do that with a flexible nasopharyngeal laryngoscopy exam. And then while we're intra-op, you could check the vagus nerve before and after dissection, or you can check the recurrent laryngeal nerve before and after dissection. And then finally, post-procedure, you can check for the vocal fold movement again via the laryngoscopy of choice. And what is useful, I think, that's depicted in this chapter and also in my practice is what to do when you do have a loss of signal and how that might impact whether you stage a procedure or not. So let's say you're doing one side of the thyroid, you're on the right side, you're humming along, but then there's a loss of signal. What do? Do you continue with the left side? Do you wait? Sometimes you can wait. Maybe there's a little traction, maybe there's a little hiccup with the nerve monitor, but if it persistently stays with a loss of signal, I think that's a good indication to stage the procedure, wait until we get some recovery before we proceed with doing the other side. Continuous nerve monitoring versus intermittent nerve monitoring is also an area that is discussed in this chapter. Continuous nerve monitoring is a little bit more invasive in that you have a device on the vagus nerve. Intermittent is really dependent on the surgeon. And that's why I think it's been shown in many large trials that it may not be as effective as the continuous. The continuous keeps you honest. You always have it on, you hear it dinging all the time. And when you stop hearing it or the volume goes down, then you know there's something wrong. With intermittent, the surgeon is the one who dictates when that stimulus is applied. And where the stimulus is applied, which is also very important to getting the accurate signal. So I think that the figure 2 depicts and summarizes the pros and cons of intermittent versus continuous. Now, I've spent a lot of time talking about the recurrent laryngeal nerve, but we shouldn't forget about the superior laryngeal nerve, because that's what really governs the pitch of our patients. And it's very, very important for people who are in the alto choir or they make their livelihood by having a specific pitch of their voice. They can't yell at their children or their spouse. And so I think that it's also very important to protect that nerve. We oftentimes forget about it and are more concerned about the recurrent, but I think it's very, very important to think about that superior laryngeal nerve. Dr. Lang and Scharf give some great pointers about how to make sure that you preserve it. Really hug the capsule and take care taking down that superior pole. But I think that those are all important reasons as to why one should use nerve monitoring. There are some arguments to use it all the time, because then you're used to it. You can troubleshoot, what happens when things don't work well, instead of using it only at the most difficult cases and you're not really that comfortable with it, and then you're trying to use it during the most difficult cases. So I think that there's some argument that can be made for doing it all the time versus just intermittently on the tough cases. But on the other hand, I think you have to be facile with adapting and knowing that you can use just a handheld probe and put your finger back behind the larynx and see if it works. Many of us have been involved in missionary work in countries and in situations where there aren't a lot of resources. And it doesn't mean that you cannot monitor the nerve. It's just monitoring in a different way. Taking care to use meticulous hemostasis is really the key to making sure that that nerve stays preserved.
Yeah, I think specifically what you said about paying attention to that superior laryngeal nerve. Everyone pays attention to the recurrent laryngeal nerve, right? And you do your level best not to have any damage there. But I remember the evolution of thought, even again, I trained in the mid to late 80s and early 90s in my residency. And even in those few years, the understanding of the important role that superior laryngeal nerve plays in really keeping your voice sounding like your voice, whether you're, as you said, an alto, whether you're a mezzo soprano, whatever you are, you should sound the way you are. And I think that's really important information.
I just want to add a comment if I could. It just because I think one of the points that Amy said that I think is a dramatic shift in thyroid surgery. I mean, theoretically, it applies to parathyroid surgery too, but certainly thyroid surgery. And I think it's maybe the single strongest argument for nerve monitoring. Even if you're someone who says, oh, I don't need this, it doesn't add anything, I never have nerve injuries, and so on and so forth. When I trained, it was a little later than both of you. I'm not trying to make not trying to make fun of you.
We're very happy to be well-seasoned
I get it.
otolaryngologists.
Exactly. Very well seasoned. But, even when I was in my training, it was routine that people said, oh, I don't have nerve injuries. I can do this without nerve monitoring, and so on and so forth. And while it has become certainly much more widespread, especially, by the way, in Europe and in the United States, there are still people who very much question its value. Like, what is the value add of a technology that in a lot of places you don't necessarily have access to, or it's limited, or it's very expensive? And I think probably the single strongest argument for its use is in cases where you're planning on doing bilateral surgery. So, and I know that there's probably some listeners when I say this that are going to fall over, but a unilateral recurrent laryngeal nerve injury is not good. None of us want it. We want it to never happen. But if it does happen, even if it is permanent, it's not certainly it's not a life-threatening condition, and it's a very kind of manageable problem, even if it is permanent. That's very much in contrast with a bilateral nerve injury. Bilateral nerve injuries, I think really there's almost no one who escapes that situation. By the way, even if just temporary, without it having really dramatic impact on their quality of life for some period of time. And nerve injuries, as Amy said, unilateral nerve injury, first side, stop, do not go to the second side. And this kind of goes back to our earlier conversation. That's true even in thyroid cancer cases. You can have a more informed discussion with the patient. You can give it the 3 months until a neuropraxic nerve reestablishes its function. But again, if I were to say to someone who really questions nerve monitoring, why do I need this? What do I need it for? I'd say, fine, you don't want to use it in unilateral surgery, that's fine. But when you're doing it in when you're doing bilateral surgery, it's really, to me, a fundamental safety question.
I agree, and I think that's actually what the clinical practice guidelines said as well. So I think we remain physicians and we remain compassionate and concerned about our patients at every step of the way. The other thing that can go wrong is being unable to preserve the parathyroids adequately and having even transient, and by transient, of course, you mean several weeks to maybe several months of hypocalcemia, which is certainly no joke as well. So there's a really nice article about preserving the parathyroids during thyroidectomy by Dr. Cottrell, which I recommend our listeners read.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
I'm Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America, and I'm having a really terrific conversation with the guest editors of the February 2024 issue, which is on thyroid and parathyroid disease, Dr. Amy Chen and Dr. Michael Singer. You can find all issues and podcasts at the website, which is www.oto.theclinics.com, and hopefully in your institutional and personal libraries. So let's continue talking, and let's talk a bit, Michael, about radiofrequency ablation. I certainly think a lot of people are comfortable with this concept for benign nodules, but I'm hearing about it for cancer. And so